Good morning. How's everybody doing today?
Good.
Good. The weather's just a little hot, right?
Yes.
All right. Can everyone see my face?
Yes.
Okay, perfect. I just want to cover some things that I think maybe we need clarification about heading into week 3, okay? So your primary book for this program is this book right here, all right? So that's, you know, what you're going to be reading a chapter out of almost every single week, et cetera, et cetera. You should have also purchased this book. Okay, can everyone see this?
Yes.
And okay, good. And Mona refers to this as a module book, even though it's material that you need to study, that you need to learn. And the worksheets that I have you print off, this is what those worksheets go to. This book and this book. Okay, I know we've had some confusion about them being called module books, etc. That's what Mona refers to them as. But honestly, they're just books that have material that you need to learn the material. And those worksheets that I have you print out, the module worksheets, help you process and learn that material. Does that make sense to everybody?
Yes.
Okay, perfect. All right. So the first thing I wanted to do was go over the tests quickly. And speak up. Everyone can see week 1 exam, correct?
Yes.
Yeah.
So I won't be able to see your comments. If you have any questions or concerns, please just speak up. Otherwise, I won't get to them until the very end, okay? So question 1, which of the following terms is used to describe surgical intervention that does not have to be performed immediately or within a short period of time? For example, a torn meniscus repair. And that's elective, okay? So your emergent would be something like a gangrenous gallbladder. Your optional would be maybe a wart removal or a lipoma removal. And then your urgent would be an API, laparoscopic API, or an open API, okay? Which of the following historical figures is considered the father of modern anatomy and changed the traditional approach to anatomical studies? And that's Vesalius. Which of the following surgical team members would be primarily responsible for maintaining the patient's operative record and transporting the patient to the post-anesthesia care unit, PACU? And so your PACU is your recovery. So your place that you go to after the operation where the patient recovers from anesthesia. And your circulating nurse will take the patient there. Which of the following surgical team members would be responsible for separating instruments and disassembling the sterile field in the post-operative phase? And that's the CST. Which organization develops national certification exams for surgical technologists and surgical first assistants and confers the appropriate credential to eligible certificates? And that's your NBSTSA. A private surgical technologist is usually employed by which of the following? And that's a surgeon or physician group. According to the AST position statement on teamwork, which type of environment contributes most to a safe and efficient experience with positive patient outcomes? Collaborative. Which term describes a physician group-owned hospital? And that's proprietary. Surgical technologists and other allied health professionals in perioperative services usually work under the direction of which hospital administrative director? And that's the director of nursing. Through which hospital department or committee would the certified surgical first assistant submit a request for privileges to work in the operating room? That's your medical staff office. Which department would provide services for repair of broken equipment or to do routine preventative checks? Maintenance and biomed. What does the acronym DRG stand for in the hospital setting? Diagnosis related groups. The federal governmental insurance programs under the general heading of CMS include all of the following except, and that's CHAMPUS or CHAMPUS. Which of the following is the membership organization for surgical technology with a board of directors elected by a House of Delegates? That's your AST. When an ARC or an STSA site visitor is sent to a surgical technology program to verify and clarify records and annual reporting information, to whom does he or she submit the findings? CAA-HEP. Which of the following membership organizations would the circulating RN in the operating room likely to join as a member? AORN. The CST and CSFA credentials are registered trademarks of which organization? NBSTSA. The hospital's infection control nurse would report any suspicion of rare or mysterious infectious diseases to which governmental agency? CDC. Which organization would employees of the Central Sterile Processing Department likely join as a member? IAHCSMM. Which federal regulatory agency is dedicated to enforcing workplace safety and preventing work injuries? OHSA, also known as OSHA. Which of the following is an independent nonprofit national organization that develops standards for and accredits healthcare organizations in the United States? The Joint Commission. A medical device or surgical piece of equipment that has failed would have to be taken out of service, and any patient injury reported to which of the following agencies? The FDA. Which of the following pioneers of medicine and surgery first developed techniques for surgical antisepsis? And that's Lister. Which specialist would likely have privileges to surgically treat diseases of the breast, hepatobiliary, and gastrointestinal systems and thyroid gland? General surgeon. After which of the following military conflicts did Great Britain and the United States begin to train and employ allied health professionals predominantly in the scrub role and surgery? That was after World War II. Which national membership organization's House of Delegates proposed the creation of the Association of Operating Room Technicians, AORT, in 1969? That was AORN. What do consciousness, problem solving, skills competency, teamwork, and commitment to continuing education represent for a CST? Professional traits. Which of the following roles is defined by the American College of Surgeons as providing aid in exposure, hemostasis, and other technical functions that help the surgeon carry out a safe operation with optimal results for the patient? Surgical first assistant. Which of the following scrubs and gowns the members of the surgical team? So that's the scrub person. The primary goal of surgical intervention is to allow the patient to return to his or her best possible state of physical and mental health. Which of the following may be performed by the surgical technologist? They can assist with dressings. To prevent the occurrences of a disease or illness is an example of prophylactic surgical intervention. Sterile team members scrub, wash their hands and arms, and don a sterile gowns and gloves before entering the surgical field. The circulator stays outside the sterile field. Preoperative responsibilities of the surgical technologist in the scrub role include which of the following? Assisting in draping the patient with sterile drapes. Which of the following is not a likely area of employment for the surgical technologist? Instructor in schools for registered nursing programs. I don't know, it's kind of obvious, right? We obviously can't be an instructor in the nursing program. The blank performs viral, microbiological, metabolic, molecular, and other tests on patient blood, fluids, and tissue samples. That's your clinical laboratory. Which of the following function within the sterile field? scrub person. The anesthesia provider is a licensed physician or a certified registered nurse anesthetist. Both require special training to administer anesthesia. Which of the following is the responsibility of the circulator? Completes and maintains accurate operative records, including notes about irregularities and incidents. To regain the patient's health and strength so the patient may resume normal daily activities is an example of restorative surgical intervention. Which of the following is not a responsibility of the circulator? Assist the surgeon with cauterization and irrigation. Even if qualified and acting as first assistant, a surgical technologist may not alter body tissue. The circulator responds to the needs of the scrubbed members within the sterile field before, during, and after the surgical procedure. To relieve or alleviate symptoms without curing the underlying cause or disease is an example of palliative surgical intervention. So with that one, that's something where they cannot, maybe for example, the patient has metastatic cancer and it's obstructing the ureters, or it's causing a bowel obstruction. And so for palliative treatment, what they'll do is, they'll go in and maybe put a stent in to keep the ureter open or do a bowel resection. But by doing that procedure, they cannot cure the cancer. They are simply doing it to make the patient more comfortable until they pass. Which may not be a member of the core surgical team, and that's your pathologist. They normally stay down in the lab and then you take specimens to them. Which of the following is a preoperative responsibility of the surgical technologist in the scrub role? And they assist circulator in opening sterile supplies necessary for the procedure. Which of the following is an intraoperative responsibility of the surgical technologist in the scrub role? Passes instruments, supplies, and equipment to the surgeon in a prescribed manner. Which of the following is a post-operative responsibility of the surgical technologist in the scrub role? Assist with moving patient to stretcher or bed. The three phases of surgical case management are preoperative, intraoperative, and postoperative. All right, did anybody have any questions regarding that test? Is that a negative? All right, so let's go to week 2. A Mayo stand holds sterile instruments and is positioned across from the sterile field. Right, so that's your Mayo stand, and we kind of talked about in the hospital tour, right? Which of the following would not be considered a part of the restricted area of the OR suite? At your dressing room, you can go in your normal shoes, your normal clothes. A member of the scrub team. I think that one says who requires maybe to be higher. Why can I not see that? Anyways, a footstool, a platform, or a life. And we showed you that in the operating room. And everyone's able to see week 2 test, correct?
Correct.
Yes.
Awesome, thank you.
Yes.
I'm not sure why. Perfect. I'm not sure why it's cutting off the questions. That's interesting.
It says it right below
The
it.
questions are written under in smaller print.
Oh, there we go. Thank you. A member of the scrub team who requires additional height to be functional uses a footstool, platform, or life. Air pressure for the operating room is positive to prevent air from entering the OR from other areas. What is used to remove blood, irrigating fluids, and secretions from the operative field? That's your suction. A blank provides area for extra sterile instruments not used on the Mayo stand. That's your back table. Which of the following is used by the surgeon to precisely cut, coagulate, or cauterize, dehydrate, or desiccate blood vessels and tissue with heat generated by high-frequency, alternating, or direct DC current? It's your ESU, or your electrical surgical unit. Operating room tables are translucent to allow for radiographs during the procedure. The surgical technologist gowns and gloves off of the following piece of equipment. That's your Mayo stand. The CST in the room is preparing for a surgical procedure in which laser is involved, should take the following safety measures, except use alcohol-based prepping solutions. And you definitely don't want to use alcohol-based, right? Because you'll catch your patient on fire. Shelley, the CST, knows that time, distance, and shielding are related to radiation. Paul, the CST in room 1, is setting up for a cholecystectomy with cholangiography. He knows that the X-ray tech will be using the blank machine and that he will need a blank and a blank to protect himself from ionizing radiation. So C-arm, lead apron, and a thyroid shield. The Wilson frame is used for positioning a patient in which of the following surgical positions? And that's prone. Which type of procedure would require an operating table with a fluid drain pan attachment? And that's a cystoscopy. So that's your urology cases. What are the Centers for Disease Control and Preventative CDC guidelines for OR air exchanges per hour? 20 to 25 with 20% fresh outside air. And that was kind of the one that we talked about in the OR or at the hospital, is that one of your books that we have you do the module worksheet out of says, I think, 15 to 20, while your big book, your AST book, says 20 to 25. When you take your national exam, always rely upon your AST book. So just kind of a heads up, if you find conflicting information, your holy grail is your AST book. Unless the patient is at risk of hypothermia, the temperature range in the OR should be between 68, so I should probably take out between or add in. And I want to say it's 68 to 72. It's constantly changing because they're finding out the warmer that it is in the OR, the slower that the warmer that it is in the OR, the more or the better the patient recovers from the surgery. So we used to keep our ORs extremely cool unless it was a pediatric patient. And now we're kind of to the point where JACO is saying, hey, if you bring up the temperature in the room, have the patient's body temperature maintain, at a standard temperature, they're going to recover faster, their wound will heal quicker, they'll recover from anesthesia faster. So that's constantly changing, and you that are going into the field now will probably see that continue to change in the next 5 years. Which of the following components of personal protective equipment, or PPE, are worn for procedures using fluoroscopy? And that's lead apron and thyroid shield. Frozen section biopsies are sent to which hospital department for analysis? Pathology. What is the term used for the process of cleaning an OR after one procedure and preparing for a subsequent one? And that's turnover. Which of the following terms relates to the potential impact on personnel from the duties of the job description or the handling and use of equipment and supplies encountered within the perioperative environment? Ergonomics. The visual representation of the components necessary to support a fire is which of the following geometric shapes? And that's your triangle. All of the following are ways to reduce personal radiological exposure except amplification. A strategy to avoid intraoperative sharps injuries is to establish and use which type of a zone? And that's neutral. And you usually have that on your Mayo stand, and there'll be a sterile orange, kind of like an anti-slip product that you open on your back table. and maybe cut a little section off and put that on your Mayo stand, and that's where you place your blades, your hypos, your swedge, anything like that. And it's designated so that the surgeon can lay the sharps on that. You'll lay your sharps on it, and you both know that that's the location where the sharps go. The last thing you want to do is have, your swedged, which are your suture needles, laid all over your field. And if you're busy and the surgeon reaches back for an instrument and pokes himself, it's not a good thing. And you don't want that, to be poked either. So they've recently started doing this maybe in the last 10 years, and it's really decreased the sharps injuries in the OR nationwide. What term is used for the smoke that is generated by use of a laser or electrosurgical unit pencil on tissue? And that's plume. And Jordan kind of talked about that and how they're finding out that people that are exposed, to large amounts of plume can actually end up with pretty serious health conditions later on down the road. Which of the following is a substance that is derived from tropical trees and that patients and healthcare workers may be highly allergic to? And that's latex. Most facilities now do not allow latex balloons in patients' rooms. I know at St. Al's, and I'm pretty sure it's the same way at St. Luke's, we no longer have latex gloves anymore. We're getting rid of latex drains. And it's simply because you may have a patient that had a sensitivity to latex, and throughout life it's progressed and they could have an anaphylactic reaction to it. And so to create a better patient safety environment, they're trying to get rid of all latex. What is the acronym for the treatment administered to a surgical technologist within 2 hours following a needle stick during a procedure on a patient with HIV? That's PEP. What distance from the portable x-ray unit should sterile members of the surgical team stand to reduce their exposure while the image is being taken? As far as possible. Truly, you want to step away from that, the C-arm, whether it be the C-arm or a flat plate in the operating room. Try to get yourself as far away from it, while also staying sterile and staying in the room. The part of the ESU circuit that delivers alternating current back from the exposed tissue to the ESU generator is the patient return electrode, which is called a grounding pad in the operating room. Harvey Cushing and William Bovey collaborated in 1926 to create the first electrical surgical unit. And in the OR, and those of you who missed this question, when in a year, if you come back and look at this test, you're going to shake your head. A Bovey is what burns the tissue, creates hemostasis, et cetera, et cetera. So you'll laugh in a year when you come back and you're like, oh my gosh, I can't believe I thought it was a heart-lung machine or the x-ray generator, because truly you just call it a Bovey. You don't call it electrical surgical unit, you just call it a Bovey. Hey, can you open me a Bovey? Can you open me a Bovey tip? It's one of the main words that you use every single day. Which of the following is commonly used as a tissue fixative and preservative for surgical specimens sent to pathology? It's formalin. What is the abbreviation for the sets of references that provide information about all potentially hazardous chemicals used in the perioperative setting and must be accessible to healthcare workers? And that's your MSDS book. Most of those are found online at the hospitals now. Which of the following should be used by surgical team members to prevent potential injury from tasks involving heavy lifting, moving of equipment or patients, and long periods of standing or sitting? That's your proper body mechanics. Make sure you all have an incredibly supportive pair of shoes before you start clinicals. If you don't, your knees, legs, the back of your legs, your back in general, hips will all hurt after an 8-hour clinical day. So just make sure that you have good shoes. Which of the following is the type of head fixation device that attaches to the operating room table used frequently or for craniotomy procedures? And that's your Mayfield brace. Which of the following is the mnemonic used to remember the steps for operating a fire extinguisher? And it's PASS, P-A-S-S, pull, aim, squeeze, and sweep. all of the following are articulating breakpoints or removable sections of an operating table, except, that's the side. What is used to remove blood, irrigating fluids, and secretions from the operating field? That's your suction. A blank is used as a receptacle for soiled and counted sponges. That's your kick bucket. And I showed you that in the operating room. Which of the following is not a consideration in determining the number of operating rooms in a facility? And that's the number of berths in the facility. Air pressure for the operating room is blank, and that's positive to prevent air from entering the OR from other areas. The emergency shutoff valve for the supply of oxygen into an operating room is designated by which color? Green. Why or where are surgical instrument booms mounted in an operating room? And they're mounted from the ceiling. And they did that essentially to be able to create more space in the OR and hopefully less tripping hazards. You know, you still have the cords that create a tripping hazard, but by mounting the booms on the ceiling, it truly does open up the OR. All doors into restricted area must remain closed during an operation to preserve positive air pressure. What is the name of the system attached to all anesthesia machines to remove waste anesthesia gases? That's your scavenger. Equipment with the highest potential for serving as ignition sources in surgical fires include all the following except, and that's your phacoemulsification probes. And they use those in eyes. The post-anesthesia care unit, or the PACU, was previously often referred to as recovery. And you'll still hear it being referred to as recovery in the operating room. They use both names essentially for the recovery unit. Which of the following is the mnemonic used to remember the steps to take in an event of a surgical fire? And that's RACE. The IV pole's primary function is to accommodate fluids or blood products. The HEPA filters used in the operating room can filter 99% of particles larger than 0.3% of micrometers. The OR should ideally be located near several ancillary units. Which of the following does not apply? And that's your general admissions. You kind of want to be close to the ER so that when you're bringing patients up, same with the blood bank. And then your central service was the downstairs. If you were at the hospital tour, we rode down in the elevators, and it's where they have supplies and instruments. You want to make sure your operating room is close to there, especially with traumas. Each operating room should have a minimum of 20 and a maximum of 25 filtered air exchanges per hour. All right, do we have any questions, concerns regarding this test? Negative. Are you guys understanding how to kind of study for the test and learn the material, read the chapter, and then do your module?
Yeah.
Okay, perfect. All right, so we're going to go ahead and start the PowerPoint presentation for this section. So it's chapter 3, which is death and dying. Not a fun section to cover by any means, but it's something that needs to be covered and kind of addressed because deaths and dying do occur in the operating room. It's not, unless it's an organ retrieval, you know, it can be a pretty stressful event for everyone involved. As a scrub tech, you are up close to the field. And if a patient does code, you will step up and help do compressions on the patient. Everyone is very supportive in the OR. You'll see great teamwork when a patient codes. Organ retrievals are another area or instance where a patient will pass. They will be declared clinically brain dead, and then a transplant team from California, Oregon, Washington, all over the United States flies in, and you help assist on those cases. While it's a joyful occasion because they're taking the organs of the patient and placing them in another patient to save their life, it's still sad because the patient on the table will not go home to their family. So let me pull this up. click out of it. All right, can everyone see the death and dying PowerPoint?
No, I can only see you.
No.
Okay. All right, what about now?
Nope.
No.
Still no?
No.
Oh my goodness. This is weird. I've never had this happen before. Let me know when you can see it.
Now, yes.
We can see
Yay! Woohoo! All right. Okay. All right, so in your book, the very beginning, it talks about Maslow's hierarchy of needs. And in one of your exam questions, your national exam questions, perhaps even my exam question, it talks about a variety of patients that come into the OR. So one, let's say one had a gunshot wound to the leg, but was stable. One had an airway issue. One had an inflamed appy, and the other one, I can't remember what it says. I think maybe the other one had an abscess. Out of those 4 patients, which one would take priority?
the appendectomy.
The airway.
The airway, exactly. Remember that. So lots of times we'll have gunshot wounds come in, and if it's in the leg and it hasn't hit anything vital, like any major veins or arteries, that patient is actually fairly stable, and we may never see them in the operating room. But if you can't breathe, that takes priority over everything. So in Maslow's hierarchy of needs, the very bottom one, and it's from the bottom up, right? So you have to be able to breathe. You need food, you need water. I don't know if you need sex, but anyways, sleep, homeostasis, and then you need to be able to either go to the bathroom, right? Have bowel movements, be able to urinate. Sometimes your most critical patients are ones that have an obstruction in their ureter and they become septic and they end up in ICU unless we can get a stent in their ureter. So being able to go to the bathroom, have bowel movements, and urinate is an absolute necessity for patients. Next is safety, security of body, of employment, of resources, of morality of the family, of health and of property. So this kind of goes back to maybe your teenagers, right? When they go into an operating room, or even your pediatric patients. One of their biggest concerns is safety. They've been taken away from their parents, and they're in environment that they've never seen before. They don't understand what's going on. And in those type of situations, it's best to be able to just kind of talk to the patient, ask them about school. We at St. Al's put cartoons on the screens. So when they come in, we ask them what their favorite cartoon is, and we pull up that cartoon on YouTube. And that just kind of makes your pediatric patients feel better. You know, all of a sudden their mind is off the environment. Love and belonging, so your friendship, family, sexual intimacy, your self-esteem, confidence, achievement, respect of others, and respect by others. And then self-actualization, morality, creativity, spontaneity, problem solving, lack of prejudice, and acceptance of facts. Inside the operating room, we treat obviously all cultural and religious patients. And it's amazing, in Boise and in the Treasure Valley, we have a very wide variety of cultures. And I think it's great because it helps us in the medical field to kind of remember that it's not just your basic religions, right? And so I will tell you, it may not be your job, but legality-wise, you may prevent a major lawsuit if you're aware of any religious preferences prior to the start of the case. And it's not something that you go over. You know, when the patient gets wheeled in, you don't say, oh, this patient is Methodist, oh, this patient's Mormon, you know, or whatever it is. But if there is something with a patient's culture or religious background that is important in the case, it is something to be mentioned in the timeout. And of course, the big one we always think of is Jehovah's Witness, and they do not accept blood transfusions. So a patient may be coming in for a bowel resection, and 99.9% of the time, you don't need blood transfusions on bowel resections. What happens if the provider or the surgeon hits a major vessel, major artery, or perhaps the patient was taking some sort of natural supplement that they didn't think was necessary to tell the provider, and it's causing their blood to be extremely thin and to not clot well. So it is important for you as a scrub tech to be aware, okay, this patient does not take blood transfusions. What is our plan B if the patient starts to bleed? Are we going to pack the patient, send him up to the floor, and wait for hemostasis to occur? So I know that that's something that's not in our general job description, but it's something that I can't tell you needs to be addressed, and you need to be a part of that discussion prior to the start of the case. So with Islam, privacy is a priority, and they may request an all-female team. And if it's possible at all, every single facility in the Valley will make this happen. Sometimes you see this in labor and delivery as well, that they want an all-female team. Everyone in the healthcare facilities are pretty respectful of culture and religious differences. So needs of the patient: physical, your genetics, physiology, or anatomy; psychological, identification and understanding of oneself; social, interaction with another individual or group; and then spiritual, understanding one's place in an organized universe. Kind of some history. Here's Sister Callista Roy. Development of adaptation model, constant state of interacting with the environment by using coping skills. Adaptation can be either rapid or slow based on the nature and type of illness or trauma, family support, or patient's culture. So how does a patient respond to a diagnosis? Is it a diagnosis of a terminal illness? Is it a diagnosis of being pregnant? Or is it a diagnosis that maybe their family member is dying of a heart attack? So even yourself as a scrub tech, you will find different ways to handle stress in the OR, whether it be breathing, whether it be internalizing, whether it be going for a run later that night, or stopping at Taco Bell and picking up a taco on the way home. You know, whatever it is, you will find different coping skills in your life. All right, Dr. Hans Selye, which was an expert in the study of stress and coping mechanisms. This is kind of what I was just talking about, right? So stress, non-specific response of the body to a demand. And there's good stress and bad stress. So distress has negative implications. So maybe it raises your blood pressure, raises your heart. Eustress, and that's good or well stress. Those are situations that kind of help us grow into a better person, even though they're stressful at the time. So types of death. So we have a cardiac death, which results from the cessation of heart function. An individual who suffers a cardiac death can donate tissues, but typically cannot donate organs. So sometimes if you're in or let's say you have a heart attack, right? So the blood and oxygen is not transferred to organs in the body. And when that happens, you cannot take the organs that haven't been receiving blood and oxygen and give them to other patients. But you can do the corneas, you can do tissue, you can do bone. So the next death is the higher brain death, which is a permanent loss of consciousness, permanent coma, and in a persistent vegetative state. So persons in a persistent vegetative state still have a functioning brainstem, which means that some form of consciousness may exist in someone in a PVS. A person in a persistent vegetative state can still breathe unaided, and a person in a persistent vegetative state has a slim chance of recovering because the core functions of the brainstem are often unaffected. And then the last type of death is the whole brain death. It's irreversible loss of all functions of the brain, including the brainstem. So criteria for diagnosis includes 3 principal abnormalities: severe coma of known cause, absent brainstem reflexes, and sustained apnea. If brain death criteria are satisfied, the patient is legally dead and no further treatment or permission to treat is necessary. The body may remain on the respirator until donated organs can be harvested. Dr. Elizabeth Kubler-Ross talks about the stages of grief in your book. So first one is denial, right? The patient doesn't want to accept that maybe they have a terminal illness, or maybe that they have breast cancer, or maybe that their family member is dying. The first reaction to learning of terminal illness or the death of a loved one is to deny the reality of the situation. It is a normal reaction to rationalize an overwhelming situation. In the denial stage, the world becomes meaningless and overwhelming, and life makes no sense. Denial is a defense mechanism that buffers the immediate shock until the mind can accept it and process it. A patient may block out the words and hide from facts. This is a temporary response that carries people through the first wave of pain. Anger. Anger is the second stage of grieving. The anger may be aimed at inanimate objects, oneself, complete strangers, friends, family, and God. The anger may be directed toward the physician who diagnosed the illness and was unable to cure it, and is often directed toward the healthcare members. Anger may be directed at a dying or deceased loved one. Patients may feel guilty or remorse that they did not change their lifestyle or heed warning signs. Anger is a coping strategy to regain control of their life. Next one is bargaining. The patient often states, if only I had sought medical attention sooner. If only I got a second opinion from another doctor. If only I had tried to be a better person toward them. What if? Secretly, they may make a deal with God or a higher power in an attempt to postpone the inevitable. Bargaining is a weaker line of defense to protect from the painful reality. 4 stages depression. 2 types of depression are associated with mourning. The first type is a reaction to practical implications relating to the illness or loss. The second type is more subtle and perhaps more private. Empty feelings present themselves and grief enters on a deeper level. A terminal illness or loss of a loved one is a depressing situation, and depression is a normal and appropriate response. If grief is a process of healing, then depression is one of the many necessary steps along the way. And then the final stage of grief is acceptance. Reaching this stage is a gift not afforded to everyone. This stage is marked by calm and acceptance. Acceptance is often confused with the notion of being all right or okay with what has happened. This stage is about accepting that an illness is a reality or that a loved one is physically gone and recognizing that this new reality is the permanent reality. So I work at St. Al's. We're a trauma hospital, and especially in the summertime, we see young adults or teenagers come in that have been in car accidents or been in ATV accidents, something like that. And the patient comes in, and if they have a head injury that's not recoverable, and we do an organ retrieval on them, that the patient will be up in ICU anywhere from a couple days to 7 to 10 days. And as we go up and get the patient and the family is there, you realize that they may still be in the first stage of grief. There's no way that they will ever get to the 5th stage, within that week or 10 days. And there's no timeline where patients or family members should be meeting these different stages of grief. Everyone is different. And years later, they still may not be at the end stage of grief. And that's okay. Everybody has a different story, right? And everybody kind of processes and goes through grief in their own way. All right, this is a video that I have posted in the module. Can everyone see this?
Yes.
Yes.
Yeah.
Okay, perfect. And in this video, it kind of talks about, even as providers or even healthcare workers, that we go through our own realization of what's happening and what's going to be the future. Is this patient going to make it? Because truly, some patients, you get emotionally involved and you want them to make it. You want them to pull through whatever it is, whether it be a heart attack or a big trauma. Maybe that patient reminds you of your mom or your grandma, and for some reason you create a personal connection to it. So anyways, in this video, it's a provider, and he kind of goes through his feelings as well as the patient's feelings and the family member's feelings.
Tonight on Frontline.
All the stuff you learned about in medical school is just a tiny little bit of what it means to be good at our jobs.
Based on his best-selling book, Being Immortal.
So many people I see, their death comes as a complete surprise.
Dr. Atul Gawande takes us inside conversations with doctors and patients about dying.
Oftentimes, what we say as physicians is not what the patient hears.
A personal journey.
My dad cried, my mom cried, I cried. He did not want to end up on a ventilator, and so let me die.
The struggle between hope.
What did we forego by pursuing treatment after treatment after treatment, which made her sicker and sicker and sicker?
And making peace with the end.
The last 4 weeks I've been surrounded by family and friends, some of the best things in my life, I must say.
Tonight on Frontline, Being Immortal.
Frontline is made possible by contributions to your PBS station from viewers like you. Thank you. And by the Corporation for Public Broadcasting. Major support for Frontline is provided by the John D. and Catherine T. MacArthur Foundation, committed to building a more just, verdant, and peaceful world. More information is available at macfound.org. Additional support is provided by the Park Foundation, dedicated to heightening public awareness of critical issues. The Ford Foundation, working with visionaries on the front lines of social change worldwide at fordfoundation.org. The Wincoat Foundation, and by the Frontline Journalism Fund, with major support from John and Joanne Hagler, and additional support from Chris and Lisa Keenan. Support for Being Mortal is provided by the John and Juana Harmon Foundation.
in medicine, your first fear as a doctor is that you're supposed to be able to fix a problem. And our anxieties include wanting to seem competent, and to us, competent means I can fix this. In fact, there's often kind of implicit promise, I'm gonna be able to fix this. I'm gonna certainly give you the best shot you can have. Nobody could have given you a better shot. And then when things aren't working, part of your anxiety is there something I missed? Was there anything else I could have done? When I started out in my training in surgery, you discover that all the stuff you learned about in the books in medical school is really just a tiny little bit of what it means to be good at doing our jobs. It's not just about how smart you are anymore as a doctor, it's about how you have to be able to work with teams and how mistakes get made and how you handle them and how you learn. Among the most uncomfortable difficulties was grappling with those cases where we couldn't solve the problem. The two big unfixables are aging and dying. You know, they're not, you can't fix them. I'm a surgeon and I'm a writer. My writing has become the way that I can focus in and begin to understand the problems that most confuse me. One case in point was a piece I wrote called Letting Go about a woman named Sarah Monopoly, whom I helped take care of, who was diagnosed with stage 4 lung cancer during the 9th month of her pregnancy at the age of 34. This was one of the most difficult circumstances. You have a young woman with a brand new baby. Of course, everybody is fighting for every chance that she's got. She was young, she was enthusiastic, she wants to tackle this. You don't want to be the downer. So you're grasping for a straw that says, well, there's something here that's going to be beneficial. Stage 4 lung cancer, we know it's not curable, but suppose she's the one that somehow gets cured. Maybe she's the one. And so therefore we should do all these things for her. Having any kind of discussion that would begin to say, look, you probably only have a few months to live. What do we do to make the best of that time without giving up on the options that you have? That was a conversation I wasn't ready to have. I don't think any of us were. Hey there. How are you? How are you? Take me back to when she's pregnant, she's doing great. 39 weeks, your due date is coming, and the collapsed lung would not allow for a C-section. It was too dangerous to be opening her up with all that fluid built up. So Sarah had Vivian basically pushing with one more. It was so difficult, but she had the baby. You want to be part of that 15% that survives more than 5 years. You want to be that part of that group so badly. And you say to yourself, why not us? You know, it wasn't about how can we have good days to the end. We didn't focus on that enough. We were trying to stabilize the situation and try to become spend a little bit of time as a family. But it was an impossible situation, impossible summer. It was just excruciating. When I came on the scene was when she got diagnosed with a second cancer. You know, in my mind, what I was thinking was I wouldn't offer this surgery because the lung cancer was going to take her life. And yet I didn't feel I could say that to people. I think we started talking about the experimental therapy that you all were hoping to get on for a trial with the lung cancer. And I remember saying something I sort of regret, which was, you know, maybe that experimental therapy will work for the thyroid cancer too. I said that, and I know it was complete.
Well, you had joined us in our sunny disposition, hoping for the best.
I knew it's not good. I mean, in other words, the reason I regret it is because I knew it was a complete lie. I just was wanting something positive to say.
I did not know it was an outright lie. You can lose your license for that.
But I think I don't think I was terribly equipped for having that conversation. And maybe you all weren't. I don't think we were. I've thought often about what did that cost us? What did we miss out on? What did we forego by consistently pursuing treatment after treatment after treatment, which made her sicker and sicker and sicker?
The very last week of her life, she had brain radiation. She was planned for experimental therapy the following Monday. You woke up and she wasn't doing so on a Friday. What happened then?
So she woke up and was gasping for air, and I tried to crank the oxygen up. I said, let's max this thing out. Maybe we'll get a bigger oxygen machine. We were so close to getting for the next potential fix. And she said, I can't do this. I can't do it at home. I'm too scared. I'm gasping for air, and I can't do this. We should have started earlier with the effort to have quality time. The chemo had made her so weak that she couldn't hold it. It was exhausting. And that was not a good outcome for the final months. It's not where we wanted to be.
In the last 3 months of her life, almost nothing we've done. The radiation, the chemotherapy, have likely done anything except make her worse. They shortened her life.
What was interesting to me was how uncomfortable I was and how unable I was to deal well with her circumstances. It felt like a revelation in that here was a case which I could unpack enough to understand. Why do we always go off the rails? It made me want to explore what other doctors were doing in these extremely difficult circumstances. What I hoped was that maybe I might learn something that I should be doing differently. I work at the Brigham and Women's Hospital and Dana-Farber Cancer Institute in Boston. They're connected together across one street. It's here that my colleagues let me observe their experiences with patients facing the end of life, the struggles and the difficult choices.
How are you?
One was Lakshmi Nayak. She's a specialist in cancer of the brain. She has to have these end-of-life discussions with almost all of her patients.
How many of your patients will you cure or help them have an end of life?
It's almost always fatal. We have, each of us has an odd patient who survived for 10 years or 15 years. But that's less than 5% of all of the patients that suffer from the most common malignant brain tumor. So yes, I don't get to tell people, I'm going to cure you.
One of Dr. Nayak's most challenging cases at the time was a man named Bill Brooks. He was 46 years old.
Bill has brain cancer. That basically, in his case, has led to raised pressure in his head. He feels really well. Bill's sister had also died of a brain tumor, and that was what he was worried of the most.
Look delicious.
It always look delicious. Everything is good for you. You eat anything. We're so lucky. We have each other. We have great families. We have great friends. We have great jobs. We live in a beautiful home. We're lucky. And then, all of a sudden, it's like our world was turned upside down.
It's a battle. Some people say don't listen to the numbers, and I always say, well, that gives me something to shoot for. If they tell you 5 years, let's go for 6, 7, or 10.
So Bill's story from the very beginning has been challenging because when I first saw him, I thought he had 5 to 10 years. That changed. His symptoms started getting more aggressive.
The headaches.
The headaches, the not being able to lie down,
I actually called Mary. I said, we don't have much time. We probably have a few days to a month. And I told her she should take time off work.
He started having pressure in his head, and we. So she's a paper towel procedure. So Dr. Knight gets very,
She takes it very personally.
She takes it very personally when she has to give us bad news. So she basically just told us to get ready. And so, you know, first you have your pity party. And then you kind of like, don't give up hope.
So after the phone call, Dr. Nyack ordered a series of spinal taps to relieve the pressure in Bill's brain. And it worked. The pressure came down, he felt better, and they had new hope. But the disease was still progressing.
You started having some pressure. Can I check a few things? Eyes wide open. What I was looking into your eyes was not the way your pupils reacted, was to see what the pressure might be. And I'm worried that the disease will be growing.
I think that it's important for us, even though it would be easy to sort of skip over this today, that we should talk about if things are not going as we hope, to just talk about worst case scenarios a little bit.
And then best case scenario too.
Best case, obviously, we'll just continue what we're doing. I think that's the right path.
What made you jump in to say best case as well as worst case?
I think that I've scared them the first time.
You're thinking back to when you talked about it
Yeah.
before, and you were worried that you'd lose their confidence if you only talked about that.
Yeah, and especially because you have been responding to treatment, it just gives them some hope, as long as you're not giving them unrealistic expectations out of treatment.
What's the third option?
There's no third option.
Has to be a third option.
We do things together. We often are finishing each other's sentences. If Dr. Nyack had said, let's talk about worst case scenarios, then I would have said, and we'll talk about best case scenarios. Have you thought at all, as far as worst case scenarios go, if you would want hospice at home or hospice at a facility?
Do it at home.
When we talked about hospice, I was reading Mary's body language that was sort of saying to me, don't go there. But given all the things that were going wrong, I felt like we had to do that.
Have you thought about anything after the enrollment?
I thought, and Mary's heard me say it a lot, is I want to see the next one to kind of see if it's showing anything or not before I start to get worried or get too hopeful. Okay. Thanks. Good to see you.
Good to see you.
It was amazing to see how my colleagues had these conversations. And it was teaching me what I might do better for my own patients. It turned out it also taught me how to do better for my dad. He got some bad news back home in Ohio. I remember I took notes in my journal around that time. Do you remember when Dad first started to get pain in his neck?
He had pain in his shoulder, and he thought that either playing too much tennis or just muscle. So when the result came, we were in shock.
We got an MRI, and as a surgeon, we knew the results were not good. He emailed the images. I opened them up, and it's a huge mess, and it's concerning. He called me up, and as we were piecing it together over the phone,
we're kind of realizing this is right in the middle of the spinal cord. So the puzzle is, how do you get this out? We're two surgeons looking at a mass. It's like two carpenters looking at a house. You know, you're not saying, oh yeah, we can't fix this. But, you know, at the end of that conversation, I'm thinking this could be a life-threatening problem.
It was hard for us as a family to talk about this, and that's despite us being doctors. In fact, talking with anyone near the end of life about their decisions is so difficult. There are actually physicians who specialize in the process. They're called palliative care physicians, people like Kathy Selvaggi, who works at the Dana-Farber. Her technique is as much about listening as it is about talking.
What would be on your checklist for what I should make sure I do when I'm doing it next time?
First of all, I think it's important that you ask what their understanding is of their disease. I think that is first and foremost, because oftentimes what we say as physicians is not what the patient hears. And if there are things that you want to do, let's think about what they are and can we get them accomplished.
You know, people have priorities besides just living longer.
Yes.
You got to ask what those priorities are.
Yes.
You got to tune the treatment to those priorities.
Exactly. And if we don't ask, and if we don't have these discussions, we don't know.
Well, I'm Dr. Selvaggi.
Dr. Selvaggi works with doctors throughout the hospital to help with their hardest patient conversations.
So, how are you feeling?
I'm not better than I was.
Eamon Alfiki was one of those doctors. He's an oncologist who, like me, grapples with reaching good decisions with his patients about dying. He'd been caring for a patient named Norma Babineau for 2 years. He said that during that time he had tried to broach how dire her prognosis was, but he had not been successful.
Let me start by giving you both an overview where we're at now, because the cancer has developed a more aggressive course to it, and it's a more resistant type, but it just keeps marching along. This is where the tough discussions come up. The disease, we knew, has been acting on. Right now, in this state, where treatment would hurt you more than help you, that's just a fact. And we not get the benefit of it.
Your timeline, or?
We could be talking about 3 to 4 months. It could be longer. It could certainly be shorter if the patient is home.
If marriage wasn't going to happen in between.
It's a question you had to ask, and I don't want to dwell on that. If I were going to bet on somebody doing better, I would be betting on you to do better than that timeline.
Our goal is, for whatever time is left, is to make it the best quality that we can.
But I need to take the baby over there.
To where?
Well, to me. Yeah, I'm going to take those pieces. We gotta find the right medicine. We can leave that aspect and take my trips.
So the really hard part I find in these situations is, you know it'll come to this point, when do you help them understand it? What's going through your mind? What does it feel like to you?
That I wish I could do better.
It still feels like a little bit of failure for us, doesn't it?
It's very much a failure. And it's hard.
But even though you knew from the beginning, you weren't going to be able to, you weren't curing this problem.
It's just a fight mentality that perhaps goes back to training in med school and just the way we are wired, and we're not trained for that other mode.
That's where we have to take our cues, because
Palliative care doctors like Kathy Selvaggi are different. They're teaching us there might be a better way in these circumstances.
So, and I think it's hard to hear sometimes the timeline, but I think it's also important to have a sense, because if there are things that you want to say or do or people that you want to see, it helps you define that time a little better. I think she knew that she was getting sicker and weaker. One of the goals was to try to get her home with hospice services, but the medications and the things that we're requiring, it's just not going to happen.
Forget
not
this
being
anymore.
controlled.
We're not even knowing whether we can leave the hospital.
Exactly.
So we didn't do that before last Monday. Feels really late in the game.
It does feel a little bit late in the game. We're all sort of taught that in order to make a difference in our patients' lives, we have to be doing something. We have to be operating, we have to be giving them medication, we have to be radiating, we have to be giving chemotherapy. In some ways, I think medicine is the easy part. It's all of this other stuff that's much harder to do. How are you?
Good, how are you?
I wanted to talk with you about, I know the other day, Norma, we talked about where to go from here. You may need more and more IV or intravenous medications to control your symptoms, and I'm worried that we're not going to be able to do that at home. What do you think about that? When you say coming close, that we're coming near the end? I worry about the same thing. And what we'll do is we'll keep you here, and we'll take care of you here. Okay? Yeah. All right, we'll see you a little later, okay? Okay. Why don't I clean this out?
Kathy Solhaji had helped Norma understand that she was dying. Still, Norma had little time to say her goodbyes. She died 10 days later.
These are really important conversations that should not be waiting the last week of someone's life. Between patients, families, doctors, other healthcare providers involved in the care of that patient.
There's no natural moment to have these conversations, except when a crisis comes. And that's too late. So I began trying to start earlier, talking with my patients, and even my dad. I remember my parents visiting. My dad and my mom and I sat in my living room, and I had the conversation, which was, what are the fears that you have? What are the goals that you have? And he cried, my mom cried, I cried. He wanted to be able to be social. He did not want a situation where if you're quadriplegic, you could end up on a ventilator. And he said, let me die if that should happen. I hadn't known he felt that way. This was an incredibly important moment. These priorities became our guideposts for the next few years. And they came from who he was as a person, who he'd always been. My dad came from a little farming village in the middle of India, thatched mud huts, no running water, a village of about 1,000 people. His father had 13 children. His mother died from malaria when he was about 10. That was when he decided he wanted to be a doctor. He went to medical school in India. Afterwards, he was offered a job in a hospital in New York City, training to be a surgeon. He met my mom and married her. And they moved to Athens, Ohio to set up their medical practices and raise a family. There, he was part of the community. And that became especially important to him after the cancer. As the tumor slowly progressed, we followed his priorities. And they led us and him to choose an aggressive operation and then radiation. But eventually paralysis set in. And then our options became chemotherapy. So the oncologist lays out not 8 or 9 different options, and we're swimming in all of it. Temozolomide increase. Then started talking about how, you really should think about taking the chemotherapy. Who knows? You could be playing tennis by the end of the summer. And that was crazy.
It made me very mad because it was, I mean,
Completely denied, right? Yeah.
you know, this guy's potentially within weeks of being paralyzed. The oncologist was being totally human and was talking to my dad the way that I have been talking to my patients for 10 years. It was holding out a hope that was not a realistic hope in order to get him to take the chemotherapy. I then pushed. We were still in the back of our mind thinking, you know, was there any way to get 10 years out of this? She basically was saying, no. And we needed to know that. Medicine often offers a deal. We will sacrifice your time now for the sake of possible time later. But my father was realizing that that time later was running out. He began really thinking hard about what he would be able to do and what he wanted to do in order to have as good a life as he could with what time he had. I guess the lesson is you can't always count on the doctor to lead the way. Sometimes the patient has. When I first learned of Jeff Shields, he had already gone through 3 years of treatment for a rare form of lymphoma. Chemotherapy hadn't worked. He hadn't given up hope, but he was also recognizing that his odds were diminishing, even as his doctors were offering him more treatment options.
Well, my experience has been that oncologists, at least my doctors, are basically optimistic. And they're always looking for a way to push the disease into remission than they are in talking about the longer term picture of mortality. I spent time talking to Jeannie, my wife, thinking about, at least for me, I want to make a decision. I don't want to linger.
We've had conversations about all aspects of what the end of his life might look like. And most of all, he says, I want to be at the front. And, you know, hopefully I'm in a position to make sure that happens. We have an appointment that I hope will result in them saying that the disease is lessened, but they might say, no, it's not under control. And then we're going to start having a conversation about mortality. And because I don't think there are so many more choices for Jeff in terms of treatment.
Hey, Rob. Hey, Jeff. How we doing?
Very good.
My pleasure. Any results of the biopsy?
Yes. The preliminary results do look like rare person's disease. And that's not necessarily so surprising. We expected that. I first met Mr. Shields about 2 years ago. At that point, he had a bone marrow transplant. And unfortunately, about a year after the transplant, he showed signs that his disease was coming back. In addition to that, he has a complication of transplant where the donor cells are actually attacking his body. And unfortunately, it's wearing him down. It almost goes without saying, but we may have to make a new game plan a week from now.
I feel really crummy or spend the last 3 or 4 weeks of my life in the hospital. It's not very good.
I bet not.
And so when we get to that point, I'll rely on you to make sure we have that conversation.
Right. And it's a group discussion for all of us. All right.
It's always a hard thing, right? How do you know if they're coming towards the end versus changing the therapy again?
Well, I don't think we ever know. With Jeff, he was a very thoughtful fellow, and thoughtful in the sense that he had considered what might happen down the road. And he made it very clear to me that if we thought some therapy might be helpful, might prolong his life with reasonable quality of life, he was happy to go for it. He also made it very clear that if we thought that things were going to go badly, or things looked like they weren't going to work, he didn't want to pursue therapy just for the sake of pursuing therapy.
It seems to me there's such a difference in these last few weeks. And we know the lymphoma is growing and sort of rampant. What I'm worried about is, could we be coming to a place where it is actually killing you? And we don't have the opportunity to really talk with the children.
You know, I am in what I consider in hospice, in other words, end stage. And we don't have, I am going to live for 4 weeks, and we are thinking, maybe they're 3 months.
Yeah. Yeah.
I think we should ask that at our next visit.
All right. Go into your Benadryl stupor.
Unfortunately, your ability to move it is up, but the other liver function tests are moving down. I can't put a particularly good spin on that. I don't know how negative a spin to put on that, but I can't put a good spin on that.
I wanted to clarify something.
Yeah.
So, I don't want to go back to the hospital. I want to die at home.
Yeah.
And that's really my goal. And so I want you, as my doctor, my good friend, to know that. The hospice people will know it.
Yeah.
Jeannie knows it. That's my desire.
It's impressive for a patient and a family to be so clear about their priorities, like Fields was. Accepting that life can be shorter than we want is very difficult. It's easy for all of us, patients and doctors, to fall back on looking for what more we can do, regardless of what we might be sacrificing along the way. And that's especially the case with younger patients. That is where a doctor needs skill, I think.
It's always a challenge how to say it, that this is not working and I have nothing more. I try to deliver the bad news in pieces over a period of time. I feel a lot of times they don't absorb all of the information. And that's why you have to keep repeating it. And
You saw how it looks.
yeah. So the MRI, there's a little change, unfortunately. There's a small area, a new spot. It's not super large, but it's there. This is the beginning of the end. I think it's progressing to an extent that we may not be able to do anything to control it. He's one of those few people in whom, you know, if there's something that you could try, it's worth trying, rather than just waiting.
What do you think about the AbbVie? I just saw it on the news yesterday. They just got FDA approval for one of their brain tumor medications.
That drug, we actually have a trial with that drug. I'll look into it. I'll look to see what the status of that is and see if it makes sense for you to get it. It's not going to be on a clinical trial for you. if we do it, we'd have to do it as a compassionate use. And I wouldn't want to give you something if it would potentially make things worse. So I'll definitely look into that. Bill brought up this particular drug, but it is experimental.
Are you at all worried that he would just have toxicity from the drug without benefit?
Yes and no. At this point, I knew that he wasn't going to live for too long without anything, so whether he, at least he felt that he could try.
Bill was only able to get one dose of the experimental drug because he was getting sicker.
The spinal taps were beginning to stop working. Push, push. The pressure in his head continued to build, and the effects were becoming undeniable. That was when he began to prepare.
I'm really declining quickly. I need a lot more help even doing basic walking and things like that. I just don't have the strength in my left side, so if I get leaning one way, I can't catch myself.
They flip them?
It took me 15 years to collect this. The more valuable and more collectible things are, from back years ago.
It just inspired you more than that.
If I die tomorrow, she's not going to know how to dispose of this properly to get the most bang for her buck.
Want me to just move all these canvas ones?
Those are going to be the good ones.
These are the good ones?
Canvas ones, yeah.
Oh, okay.
Yeah, that one's a good one.
Oh, I like that one.
I'm just overwhelmed with everything. The mental roller coaster has been the hardest thing to deal with. It's like, okay, am I dying? Am I not? Can I function? Can I not? And then they're trying to tell you, stay positive, keep hoping, keep fighting. And I'm like, I've been doing that for 2.5 years. I'm at the end of my ropes as far as that goes. I can't take any more bad news. I'd rather go into the meeting and have her just pull a gun out and shoot me and have to listen to her trying to be nice while she's giving me bad news. Like I said, I'm a positive person, but I'm at the end of my ropes with it. I'm gonna fight as best I can.
Accepting death comes with incredibly complex emotions. Bill's hopes for more years had turned to weeks, and the question became when to let go of treatments if they're not helping. To accept what Dr. Nyack and Sandra had been conveying about considering hospice.
I think we need to talk about what's been going on for the last few days. The fact that you didn't respond to the spinal taps. I wouldn't want to put you through any more spinal taps. There is going to be a time when we're not going to be able to deal with the pressure. With the steroids. We will be able to help with pain and in making you comfortable. I'm worried that your disease is progressing quickly. We've talked about, hospice before. And I think this is the time where we need to discuss a bit more about it.
We're not talked many times. My thought again is I'm not afraid to die, but I'm afraid of all the suffering that goes beforehand. So we're trying to find out why that come to pass, just like say goodbye to each other.
It's in your head over and over again. You don't even want to think it's a reality. Sorry. Really hard.
It was impressive just being able to be silent for a while. Were you deliberately trying to be silent, but let it happen?
Yeah. I think it's important to pause at the right time. Sometimes it's a lot of information.
Hopefully that's bad news for the day.
At this point, it's just making sure it's as comfortable as he can be. And that's the most important thing. What's working against him in a way is that he's young and strong. It'll just mean that he'll linger longer. And this is it, yeah. It's basically just let him just go peacefully. Unless there's another miracle.
Okay. But anyway, like I said, it just depends.
It's not depends on him, so.
Yeah, I'm gonna go check on him. I just want to make sure he's okay.
Are you okay? I'm right here, sweetie. Just want you to be comfortable.
Bill died 2 days later.
As this whole time began to unfold, I began to realize how difficult it was. Partly because our house was not organized or arranged to comfortably do this. Suddenly in the hospital bed in the middle of your living room.
I'm gonna need you to help me pray.
Don't know that. Sure. Now we're gonna help Papa take his slippers off. Can you do that? You want it to be as comfortable and happy a place for him as it can be. At the same time, it's it's sort of the elephant in the room.
Have I talked to you at all about my thoughts on dying?
Yeah.
Is it too hard? Okay. Let me just tell you this, I'm not afraid of dying. I've had a long and wonderful life. And one of the nice things about being at the farm is that you realize everything is. There's a cycle of life. The cows die, the trees die, the grass dies, the fish die, and people die.
Aren't you sad that you're going to be missing out on a lot of things?
Well, I will be. And, I had hoped to have another 10 or 15 years. But you don't always get what you want. I love you.
I love you too.
See you in a few minutes.
In those last weeks, as his space narrowed to that bed, it grew in terms of the people he was trying to. I hate to cry. I'm sorry. But that's another one of those paradoxes, you know, as your world comes closer and smaller, it becomes bigger and bigger. And he was seeing that.
The last couple of weeks I've been surrounded by family and friends, and it's been terrific. Some of the best days in my life, I must say. But then there's a downward trend that's more rapid than I had expected. I felt great during that time, and my body was in rapid decline. Since then, my mind has been in rapid decline. I get confused. But I'm still a happy guy.
Jeff Shields' words about his last weeks being his happiest seemed especially profound to me because they were among his last words. He died just hours afterwards. In medicine, when we're up against unfixable problems, we're often unready to accept that they are unfixable. But I learned that it matters to people how their stories come to a close. The questions that we ask one another, just as human beings, are important. What are your fears and worries for the future? What are your priorities if time becomes short? What are you willing to sacrifice and what are you not willing to sacrifice? My father answered these questions. He entered hospice 4 months as an internat before he died. And he was a person mostly during that time. He was not a patient. And my dad Skyped with everybody back to his village in India. He had me and my sister come there and meet with him. And he remained in control of the priorities that were most important to him. I remember sitting in a chair, reading the newspaper, light coming in the window. My mother and my sister were having a conversation. And then we realized he wasn't breathing. We waited to see if there would just be one more breath. And there wasn't. My dad made his wishes for what his life would be like to the very end very clear to us, including for what should happen even after the very end. He wanted to be cremated in the traditional way, and he wanted his ashes spread on the candy further. We took his ashes, my sister and my mother and I, to the ancient city of Varanasi, the oldest cities in the world. A Swami and a boatman taking us out in a dinghy, and it was an amazing thing.
Millions, literally millions of families have brought the ashes of somebody in their family who's died to the Ganges. That connection to people going back that many years makes you feel like you're connected to that many years going forward as well. You're just this speck in time. I felt he had
brought us there and connected himself to all that was important to him. How is dying ever at all acceptable? How is it ever anything except this awful, terrible thing? And the only way it is because we as human beings live for something bigger than ourselves.
Frontline is made possible by contributions to your PBS.
All right, I kind of want to hear what everybody thinks of that video. That provider, I think, got to see both sides, right? Go ahead. Let me hear a couple people tell me your thoughts on that video.
Yes, I didn't see all the stages that you talked before. It looks like that the doctor give a time to them to accept the status, and they accept. I didn't see the anger. They don't, for me, they don't look like anger or depressed. Oh, I don't know. Yes.
Yeah, the anger, depression.
I need time to think about that.
Yeah, it's a pretty heavy video, and I'm going to be hitting you with another video at the end of this lecture. And after this lecture is over, I want you guys to go outside, get some sunshine, and just kind of decompress. Working in the medical field, you're going to feel some of these emotions. You're going to end up losing patients. And there's going to be some days where you go home with a heavy, heavy heart. Mm-hmm. And those are the days where I want you to hug your family.
I totally agree with Alexandra. I think she said that we really got to see all the different emotions and the phases of grief. I think as healthcare providers, it's really important that we acknowledge those phases and understand that there's no set time frame. I mean, working in hospice, I did that for like a good year, and it doesn't get any easier. Yeah.
Yeah, it really doesn't. My mom was diagnosed with a glioblastoma, which, as we get farther along in the program, you'll learn what that is. But essentially, it's a terminal brain tumor. Oh. And the patients are given, I think, 12 to 15 months maybe. But I will tell you, you working in hospice, all the props to you. Our hospice workers for my mom turned out to be some of our favorite people. And they really do help you go through all the emotions, you know, as you're losing that family member. And it's such a tough, I think it's a tough profession. So I'm super impressed that you work in hospice. I absolutely adore those people that choose to do that profession.
Thank you. I feel like we really do mourn along with the family members. You know, you get so attached to these people.
Yeah, and you're going into their home and get to know their family members and their story, and that's pretty impressive.
But I agree that the doctor need to be honest with the patient and their family. So this is the priority for them, I think.
Agreed. And you know, I think the hard part is each patient handles diagnoses differently emotionally and physically. So sometimes it's hard for me when a provider says, oh, well, you have 10 to 15 months. And when my mom was diagnosed, she asked the neurosurgeon, how long do I have? And he said, you could go out tomorrow and get hit by a bus. And he said, how long do I have? I could get hit by a bus tonight. So he said, I will never tell you how long you have, but he said, you will be living with cancer for the rest of your life. And I thought that was interesting. And he wanted to make sure that she had a positive outlook on life, because you really don't know, you know, once someone is giving a diagnosis. of a terminal illness, you don't know how long they have. And so one thing Dr. Chuka told my mom was to live each day to her fullest. And I think that's important.
Absolutely.
Does anybody else have anything they want to add?
Ray, we can't hear you.
Now can you hear me?
Well, we could hear you, but I think Ray is trying to say something. And
oh, Ray's trying to say something? Okay.
Yeah.
Ray, do you want to try again?
I see the chat right now too, and I think Christina just made a point as well.
Okay. It's all good, Ray. I still can't hear you. I'm sorry. Dang it. Poor Ray. Ray, do you want to type it out on the messages? And Christina, all good, no worries. I appreciate any input because I think this is a super tough discussion. So again, after the lecture's over, I want you guys to decompress somehow, okay? Because it's a pretty deep topic.
Another point that's not directly related, but working with the pediatric unit, I remember kids would get really scared if we said, oh, you're going to go to surgery and you're just going to go to sleep. But they had parents previously say, like when the dog died, they went to sleep. And so I think that's another point. Like you be very clear and concise about like what going under surgery means, and like when somebody or a pet does pass away, saying that they passed away versus they're going to sleep, because that would really scare the kids.
Absolutely. And then the kids perceived that they weren't going to come back to their parents. And I think the hard part is with children, whether they've watched cartoons, TV, overheard conversations, each one of them may have a different perception or an idea of what will happen in surgery, right? Or maybe if they're having chemo or radiation. And so that's such a valid point. I didn't even think about that. And I have 3 little kids and we foster for the Humane Society. So I appreciate you bringing that up. So Ray said, as a CNA, I have had a lot of residents die. It is hard to deal with because I grow to love these people. All right. Thank you for all the comments and input, by the way. I really appreciate it. I'm going to hop back to the PowerPoint. Can everyone see this screen?
Not yet.
No.
Okay. And I apologize. I had carpal tunnel surgery yesterday, and so my right hand is kind of numb. So I'm trying to do it all left-handed.
In that case, very impressed.
All right, tell me when you see it.
We aren't able to see it quite yet.
All right, let me give it a few seconds and see if it will upload. Not yet. gonna work down through these slides real fast, just make sure we're in the right spot. Okay. You guys able to see that now?
Yes.
Yeah.
Perfect. All right. So categories of causes of death. So you have your accidental, right, which is your motor vehicle crashes, your falls, poisoning by solids and liquids, the drownings, the fires and burns, suffocation, firearms, machinery, your terminal deaths, cancer, AIDS, prolonged or chronic ones, the Alzheimer's disease, asthma, and hypertension. Sudden deaths are your myocardial infarction and SIDS. All right, so your organ donation. So at each facility or at each organ donation, what I want to say, not company, but kind of like healthcare facility. So OHSU, Stanford, those are some of the big ones that come in to St. Al's. But we have, and I want you guys to remember this phrase. I'm giving you another freebie, okay? A gift of life coordinator. And this is the person that has to approach the family members, which is a tough job, right? Because you don't know what stage of grief that family member is in. And you have to approach them and then try to ask them if they want to do an organ donation. If it doesn't state it on the family member's driver's license, family members can still be approached. Even if it is stated on the driver's license, there's still that job of approaching that family member and letting them know, you know, because they may not know that their son or their daughter, you know, or their mom or dad or whoever it is, had that on their driver's license to be an organ donor. And then kind of letting that family member know, hey, tonight or tomorrow morning, we would like to move forward with the organ retrieval. And I want you to know that during these cases, the utmost respect occurs. It's quiet. They sometimes have the music playing of whatever that patient is, patient liked, right? Whether it be country, classical, pop, whatever. The coordinator really tries to make this a very respectful and a very personal experience for that patient. And so they'll have the music playing. We're extremely quiet as the OR team. They bring the patient in, place them on the OR table, and it depends upon whether or not this family is doing a cardiac death or if the patient was declared legally brain dead. If they're legally brain dead, we go ahead and get the patient prepped, draped, and start on the surgery. And then as soon as that organ retrieval team leaves our OR, they immediately hop on a plane and get the organs to their designated location. If it's a cardiac death, which is I'll kind of talk about later on, the family members are actually brought into the operating room, and the patient is extubated, and then they get to stay until the patient takes their last breath, which again, extremely tough on the family. It can be pretty emotional for the OR staff. For the ones where the family member isn't there, they usually read letters from family members to that patient, which again, extremely emotional, but it's an incredible surgery to be a part of. After the surgery is done, you know, the organs then are taken and given to people on transplant lists. And I'll tell you, one of the coolest things that happens about these surgery and being part of that OR team is that we all receive a letter from whatever transplant team came to our facility. So whether it be OHSU or Stanford, you actually get a letter saying thank you for your time and efforts in this surgery. And then they will tell you where those organs went and kind of about the patient that received them. So for example, Mr. Jones's kidney went into a 55-year-old father of 4 who loves to hike and play baseball. And it just it creates that, what do I want to say, like complete circle that the emotions that you went through for that organ retrieval had a happy ending. You know, that patient that gave up their organs saved the lives of numerous people. And I hope, as tough as that surgery is, I hope each one of you get to experience it at least once, just because I think it's an incredible experience. So at most facilities that do the organ retrievals, they have what's called a walk of honor, and it's where employees line the hallway in the ICU as the patient is transferred to the OR. At St. Al's, we don't do this yet. It's kind of a new thing that's, you know, maybe been created maybe in the last 5 years. I know that St. Luke's does it. It was on the news for St. Luke's maybe 6-8 months ago. So anyways, I want to share this video with you. All right, can everyone see the video?
Not yet.
The PowerPoint.
Not yet.
No.
All right. Now can you see?
Just see you.
Just see me. Okay, perfect. That's better than where we were. Okay, now can everyone see?
Yes.
Yeah. Perfect. All right, so this is only 6.5 minutes. Kind of hang in there. If you need to go get some Kleenexes, go to the bathroom, get a drink of water, feel free to do it, okay? So before I continue this video, a little back history on this. This was a teenager from Evansville who was declared brain dead from playing the choking or doing the choking hazard internet challenge. They said he was incredibly outgoing, but that his family chose to donate his organs. So this is the walk of honor. You'll see everybody from nurses to engineering to environmental services to admin lining the hallways of ICU as they take him to the OR.
Angel, are we taking a break or do you have it playing on a different tab?
Are you guys not seeing this?
I just see the web link to it. It's not the video.
Okay, perfect. Take a break and I'm getting it ready, okay?
Okay, perfect.
All right, you guys see the screen of the video?
Yes.
Yes, okay. All right, is everybody back from getting a drink and go in the bathroom?
Yes.
Okay, now can you see the full screen?
Yes.
So you should see the OR team coming out of the elevator, right?
Yeah.
All right. Okay, so here we go. Oh no. All right. Hold on. My computer's trying to reset and snooze. Okay. Now can we all see the video one more time?
Now it's on
No.
you.
Now it's what?
It's just on you.
Oh, it's just on me. Cool. Let's change that. Okay. How about now?
No.
What the heck is going on?
There we go.
Yay! Blackboard's just being a little bit slow today. Okay. Can everyone see?
Yes.
Video of them coming out of the elevator? Okay, perfect. Thank you.
place was by a body of water with a fishing pole in his hand. Mason was always at victory. You couldn't help but to cringe as you turned around when Mason would say, "Hey, look what I found in the woods." Mason was afraid of having, and it wasn't uncommon to see him carrying a snapping turtle or other some semi-dangerous creature from the woods. Mason also loved to work with his hands. Mason's workbench was his happy place. If he wasn't taking apart something that was hopefully not needed anymore, he was making things for lovers. Mason also loved trivia and talk about the most obscure things for hours. Mason had a kind of patriotism that could bring a tear to the eye of a five-star general. He would make sure that if the American flag hit the ground, it was disposed of properly. If he saw a veteran, he would remove his hat, walk over, shake their hand, and thank them for their service. Mason could always see the beauty within. This is how his dog Skippy came to be in their lives. When everyone else walked by this fairly unattractive dog in the shelter, Mason knew he was the one. Mason loved his Skippy. Mason was Mason. If he knew Mason, he would understand that there really is no one single word in the English language that describes how amazing Mason was. We know in our hearts that all of these wonderful things that made him the way he was belong to others. He was bigger than life, and this world wasn't big enough for him. He always lived life on the edge. We are so very proud of our hero. This room becomes sacred when the family entrusts us with the one of their most precious possessions. Mason is dear to them and a hero. We honor Mason by conducting ourselves as though the family were present. We treat Mason with respect and dignity above all else.
All right, can everyone hear me okay?
Yes.
Yes. So you can see pretty how heartfelt that was. You know how much of the medical staff is involved and how heartbreaking that is for the family. The medical staff try to make it as personal as they can. You know, by reading the letters and try to help the family go through that grieving process. You heard the clapping at the end. Because organ donation is perceived as a heroic effort, I think, for everybody involved, the patient as well as the family members. It's tough watching a family member being taken to the OR and knowing that that's where they're going to take their last breath, right? Instead of you being able to be there for their last breath, unless it's a cardiac death. All right, can everyone see the PowerPoint presentation?
Yeah.
Yes, okay. All right. So this is about the donation after cardiac death. So this is the organ retrieval where the patient is brought to the OR. Hold on, let me make this. There we go. They're brought to the OR. When they come in, the OR is entirely set up. So you as a scrub tech will have set up all your instruments, just as you would a regular surgery. Patient will be brought to the room. Patient will be prepped and draped in the normal fashion. And then at this point, this is where it changes. You'll have sterile drapes. They're called 3/4 sheets or some sort of other sterile drapes placed on the patient and then covered by blankets. The OR will be sectioned off with either blankets, bed sheets, and they hang them from IV poles, and it separates the area where the family and the patient are from the back of the room where your instruments and your Mayo stand will be. The OR staff leaves the room. As a scrub tech, you can stay in the room, but you stay behind the drapes or the bed sheets, and you stay sterile. The transplant team stays close by, so they'll stay in the core area. If you did the hospital tour, you remember the little sub-sterile area that had the autoclaves that we kind of entered and exited the room. Staff sometimes will stand in there. Family members are brought in to be with the patient as they are removed from ventilation and pass away. So they have 90 minutes from the time of being extubated that they have to pass away for the transplant team to use the organs. So, and there's certain intervals. I believe if the patient passes away, and I may be wrong and it may be different with each transplant team, but I just did one maybe 6 weeks ago, I think. During summertime, we do see a lot of these cases. I think one weekend they had maybe 3 to 4 at St. Al's. But anyway, so I think it takes maybe 30 minutes to take the heart, and then it's different intervals, and also different transplant teams have different time limits. You know, so OHSU may take the kidneys at 60 minutes, and then past 60 minutes they won't take them, but maybe Stanford will take them at 90 minutes. So it kind of differentiates. Once the patient passes away, the family members are taken out of the OR, and then the OR team quickly comes into the room. The blankets are taken off the patient. The drapes that were placed over the sterile drapes are taken off very carefully, and then you quickly begin the surgery because time is of the essence, right? So those organs are no longer receiving oxygenated blood from the heart. So you really work quick. Sometimes you have 2 transplant teams there. So the one I did 3 months ago, I had a Stanford team there that was taking the heart. It was from a young female patient. And then the OHSU team was there taking the kidneys. And I'm not sure what else. I think we took 3 separate organs during that retrieval. So you work very quickly. In some ways, this type of death is harder for family members, right? Because they're waiting for their family member to pass. If the patient does not pass, they are moved back to the gurney and taken back up to the floor where the family members can stay with them until they pass. All right, here's what I want you to remember. Okay, as you enter your medical career as a CST, every patient has a family, right? You will work on prisoners if you work at St. Luke's, St. Al's, West Valley, you know, and any of those nonprofit facilities. You don't get to know their story, but they do have a story. And we don't know why they're in prison, but I want you to try to remember to treat every single patient the same, okay? So every patient has a family, they have a story, and they deserve the best care that we as CSTs can provide for them. and every patient is a person. Provide the same care to a prisoner as you would care for a high-ranked athlete or politician or professor. All right. So that is the end of my lecture. Do you guys have any questions, concerns? Is there anything I can answer for you? Again, I know this was a deep lecture, pretty emotional. Truly, I want you to go outside, get some fresh air, do whatever you need to do to kind of fill your bucket back up. And then I promise next week's lecture will not be this deep. All right, any questions, concerns? Your test opens this Friday and closes Sunday night. All right. Oh, hold on, I see comments. Yes, Christina, I wish my camera wasn't working either today. Thank you, Lindsay, I appreciate it.
Thank you, Angel.
You bet. All right, everybody, please, please go out and fill your bucket emotionally and go hug your family and friends a little closer. All right, have a good rest of your day.
Bye, thank you.
Bye, have a good day.
You too.